I think this is a very timely topic. Title of our topic is Incorporating New PET Imaging and Theranostic Approaches into Prostate Cancer. So just to give a little bit of introduction to the Society of Nuclear Medicine and Molecular Imaging, we're a society that represents a little over 15,000 members. Around 59% of our members are technologists, and we have a little over 6,000 physicians. And these physicians come from multiple different specialties: radiology, nuclear medicine, medicine, cardiology, and whatnot. And then we also have scientists in our society who are typically physicists or radiopharmacists. The journal for our society is the Journal of Nuclear Medicine, which is our flagship publication. Has an impact factor of 6.65 and is the 5th highest impact factor with regards to imaging journals in the world. And there were 22,728 citations in 2016. Here's our Facebook and Twitter. That's my Twitter handle. That's our society Twitter handle and our Facebook account. So nuclear medicine, for those of you who are familiar, is typically thought of as an imaging-based specialty. And it's based on SPECT gamma camera imaging, and that's typically used for bone scans, which we're all familiar with. And then PET-CT, which is positron emission tomography, which is sort of a newer tool that we've had over the past 10 years, which we typically use fluorodeoxyglucose. And these are some of the images that can be outputted by these different imaging tools. This idea of therapies is not new to nuclear medicine. So many of you are familiar with iodine-131, Zevalin, and these other therapies that we've used in nuclear medicine. But that portfolio is growing. So Xofigo, radium-223, was approved by the FDA a few years ago. That's a big part of our practice now. And we'll hear about other therapies that we'll have in the future. The difference with these radiation therapies is the fact that we inject these radio particles and they distribute throughout the body and then localize to different areas. So that's sort of the difference between this and radiation oncology, which typically takes sealed sources of radiation and directs it toward a specific target. So we use the tracer principle, which is more based on just physiology and the body's circulatory system. This is sort of an interesting advance that we're having that we're going to talk more about today, but this idea of Theranostic. So if you could combine imaging on the diagnostic side and therapies to really find the patients that are going to benefit from a certain thing. So this goes back to the idea of right patient, right test, right therapy, right time. So if you have a population, you could use diagnostic imaging to identify those patients that are positive for a target. So then if you use diagnostic imaging, you could separate them into those who are positive and those who are negative. And obviously those who are positive, then we can proceed with targeted therapies. And that's something that we're going to hear about more today. In the end, it's teamwork. You know, a lot of the things that we do in nuclear medicine are great, and I think we continue to push the field. The oncology field continues to push forward, surgery, urology, everyone continues to push forward. But in the end, it really is a team-oriented approach. So as you can see, we know what we're talking about. That being said, we actually don't. And that's sort of the message that I want to give is a lot of these things are still being sorted out. And I think one of the purposes today is for us to sort of communicate what we know, but we also want to hear back from all of you, and not just today, but continually with regards to, all right, these are the things we need to be working on, and actually let's, work towards finding some of those answers. Because, again, we need to sort of cross-pollinate to really come to some meaningful endpoints and meaningful change with regards to practice. All right, so when it comes to nuclear medicine and imaging, we've been stuck with a lot of bad technologies for multiple decades. So bone scans were first introduced in the 1970s, and we were kind of stuck with them for a really long time. And, they've served us well, but there are a lot of limitations with bone scans. There are 2D images, they're planar. They don't really have great resolution, and they don't image the disease itself. It images the bone's response to disease. And there are limitations, and we are all aware of the flare response, which is a problem. So using this for treatment response has always been a problem. Fast forward to 2012, in the US, we saw the FDA approval of C11 choline. only at the Mayo Clinic. This was a huge advance, but the problem was it was so limited. We all heard about it, we read about it, but none of us could get access to it because you had to go to Rochester to get this study done. And that was because of the 20-minute half-life, because it was a carbon-11 compound. Fast forward 4 years, we have F18 fluciclovine, which is trade name Aximin. That was FDA approved. That is an F18 molecule, which has a half-life of roughly 2 hours, which is similar to what we use for lymphoma and all the breast cancer imaging. So that could be shipped all throughout the country. So that was commercializable, and that was a huge advance. So I imagine at this point, fluciclovine is probably available throughout the country, which wasn't true maybe 6 months ago. And then looking to the future, we've all heard a lot about PSMA. It's clearly very ubiquitous in Europe, in Australia, South America. Here in the US, INDs, trials are using PSMA. But we're going to see more of this very soon. And I think this is going to be another practice-changing moment. A lot of this brings up a lot of questions and controversies with regards to practice. This idea of oligometastatic disease is very big now. We have some burgeoning data with regards to how you manage oligometastatic disease, but I think we need to define it better. And we also need to figure out how we best treat oligometastatic disease. M0-CRPC is another controversy. We're all familiar with Prosper and Spartan that was presented at GU ASCO in February. That creates another issue with regards to how you deal with imaging in those settings. This idea of low volume versus high volume metastatic disease is another question that was based on bone scans and CT, not this advanced imaging. So again, maybe that's something we need to redefine. Another issue that Dr. Slovin brought up was this idea of PSMA non-expressors. In the literature, I think maybe 10 to 20% of prostate cancers actually don't express PSMA. So what do we do with that? If we're going to use this in a diagnostic setting, we keep talking about PSMA, sort of the holy grail and the perfect weapon, but what about the PSMA non-expressors? When it comes to theranostics, there's a clear relationship between the two, but on the diagnostic side, this idea of PSMA non-expression is something we need to deal with. In the end, patient care in metastatic disease requires a multidisciplinary approach, and I think there are a lot of different people that are involved to really properly care for our prostate cancer patients. And since we are representing Society of Nuclear Medicine, just sort of emphasize that nuclear medicine is playing a larger role in the management and care of these patients. So my request would be, wherever you may be in whatever type practice, really reach out to those providers who provide the nuclear medicine services and figure out how you can work together. Provide feedback to them so they can improve their practice. Hold them accountable to make sure they are providing the latest care and they're providing at the level that you guys need it at. So again, I think that's the only way we move forward together. All right, so I'm going to turn this over to Dr. Slovin to talk a little about radar, which I think is an interesting topic and very timely.
Thank you, Phil, and good evening to everyone. This acronym, if you will, came about in a very peculiar way. So over the course of a number of years, David Crawford has been the inspiration to many of us when it comes to stirring up the kettle, as they'd like to say. So he got a big idea one day and says, as a urologist and you as a medical oncologist and you as a radiation doctor and you as a radiologist all look upon things very differently. And it's getting to the point that we're seeing people who have rising PSAs right after they have surgery. We have people who present a little bit later, and then the question becomes, how do we manage them? What do we do about imaging? And so everybody at the table, when we first started talking about it, had their own opinion, or his or her own opinion, as to how we would best deal with this. And so radar number 1 was born, and subsequently was followed by radar 2. This was an attempt really to try to come up with an algorithm of how to use imaging, at least as the cancer is evolving over time. Everybody knows that prostate cancer is a very dynamic process: localized disease, biochemical relapse, non-castrate metastatic, castrate metastatic, and then we have the evolution of this peculiar neuroendocrine entity that's been coming. But no matter how fast you go, you will learn one thing, and that is we are in a position to try to identify the disease earlier in each of these changes as the disease progresses. So very early on, we came up with this algorithm in Radar 1, which was, what do we do when we have somebody who's newly diagnosed? This was the algorithm that we came up with. Don't do anything unless the PSA is 10 or greater, or the Gleason score is greater than or equal to 7, et cetera. Keep in mind, there's always been pushback from the insurance companies. And a lot of our aggravation when we were sitting there talking had to deal with the fact that the insurance companies, your clinical acumen should supersede the input of somebody who is really not a healthcare professional, but is sitting there on a stack of dollars who says, well, this doesn't fit into our algorithm of what we think should be done. We know better, but unfortunately getting these tests done. So the idea, again, behind Radar and the group meetings and Radars 2 and subsequently now 3 was try to gather data to really make this a much more cohesive and unifying approach to how we work up patients. For those patients who had a rising PSA right after surgery, the suggestion was maybe we'll do a first scan when the PSA was between 5 or 10. Imaging frequently, if negative, from previous scan, and then you go on and on and on with different recommendations. If you had patients who had castrate non-metastatic disease, then the thought was maybe we should image a little bit sooner. But the question is, what was the best imaging? And what we've always been using has been bone and CAT scan. So when we hit Radar 2, it was a little bit different. We felt Radar 1 had a tremendous impact because for the first time in a very organized manner, for each clinical state, if you will, or stage of prostate cancer evolution, we had an idea of how we felt it would be best served with particular imaging. When we got to Radar 2, we started to build on Radar 1 and say, you know what, is there something else that we're doing? Maybe we should be more focused. And in fact, we developed what we called therapeutic layering. And that was to just find a state and determine how you would proceed with integration of different therapies with each change in the clinical landscape, if you will. The Radar 3, which will be out very shortly, and this was really due to David's foresight. If you did very well with 1 and 2, why not have 3? And that had to do with the next generation imaging. I don't know that there is anybody in this room, I don't care how great your background is, who can definitely tell you whether or not one particular imaging would be appropriate for the others. You heard Phil just mention that there's a discordancy between some imaging. What if the cancer is a non-PSMA expressor? That can make a difference if you want to send somebody for a lutetium J591 scan if you have metastatic disease, which is a therapeutic imaging treatment as well, only to find out that it didn't work. And why didn't it work? Well, patient didn't have PSA expressing disease. So we may have a very different kind of entity when it comes to the behavior of the cancer. So what Radar has now essentially done, it's done a better definition of defining, well, at least 2 FDA-approved procedures, which is the choline-11 and the flucyclovine or Axumin. But what it's now doing is laying open the field in terms of how do we proceed with using these drugs. They're drugs because they are targeted agents and they still get metabolized and the like, but can we make recommendations as to how to best treat our patients so that we can identify the disease earlier, treat them earlier, and perhaps impact significantly on the timeline to their disease progression. There is another approach that we looked at, which was we tried to break everybody down into groups once again, and what you can appreciate in the blue is what we had in Radar 1 in newly diagnosed and biochemically relapsed M0 and the like, and then this is how we have changed it in the Radar 3. So whereas newly diagnosed, you had to consider scans if the PSA was at least 2, here for newly diagnosed, it's really if conventional imaging is equivocal or negative, but you have a high suspicion of metastatic disease, by all means consider one of the next generation imaging, choline, et cetera. If you're biochemically relapsed, you may remember first conventional scan when PSA level was between 5 and 10, and it was up to the essentially the lot of the draw in terms of how you want to follow the patient. But now we were thinking of considering next generation imaging when the PSA was greater than 0.5. And if the PSA was less than 0.5, then maybe we just would keep an eye on that patient. The M0 patient is very challenging because, again, there's been no standards of care, and our thought was maybe consider that only in the setting of somebody whose PSA is really doubling or tripling very quickly, using it about less than 6 months, and then decide when the therapies. And of course, I think it's common sense in terms of M1 disease where you would utilize bone scan, CAT scan. So essentially, this is not replacing doing a bone scan and a CAT scan, but there are high-risk patients who indeed probably have a tumor that will behave in a much more lethal rather than an indolent type of way. And therefore, if you can identify a metastatic focus and treat it, either locally or systemically, then I think that may have a tremendous impact on how we go forward in monitoring the patient.